Good morning, everybody. It's 8:30, and we will call the January Douglas County Board of Health meeting to order. For the record, there is a copy of the Open Meetings Act on the north wall. It usually is over there. I don't see it, but it's over there somewhere on the north wall of the legislative chambers. There was official notice of the meeting printed in the Daily Record. And with that, I ask for roll call.
Rogers?
Here.
Festerson?
Here.
Weiss? Here. Wilkin? Here. Espinoza? Here.
Before we go to the official approval of the minutes, we'd like to welcome our newest member, Council President, Councilman Peace Festerson from District 1, to being a new board member. It's been a practice of the board for the last 10 years or so to try to have a representative from the council, and we've been honored to have them here, so we want to welcome Councilman Festerson to his first meeting.
Thank you, appreciate it.
With that, we will go to item 2 and approval of the minutes. Is there a motion to approve item A?
So moved.
It's a motion by Wilkins. Is there a second? Somewhere. Second by Celine. Ms. Espinoza, roll call.
Wilkin? Yes. Rogers?
Yes.
Weiss? Abstain. Espinoza? Abstain.
So I should probably abstain not having been here, but do you need the vote?
Well, we'll hold them over to the next meeting.
Okay.
We'll go to item 3, which is a public comment period. There's an opportunity for anyone to comment on on an item that's related to public health that is not officially listed on today's agenda. Are there any public comments out there? Looking online, seeing none. We'll go on to item 4 and approval of the action items, item A and B. Is there a motion to approve items A and B?
So moved.
Motion by Wise. Is there a second?
Second.
Second by Wilkin. Any questions? Roll call.
Festerson?
Yes.
Rogers?
Yes.
Wilkin?
Yep.
Espinoza?
Yes.
We'll go on then to item 5 and the health director's report and issues for discussion. Dr. Hughes.
Well, I haven't been up here for a while.
Yeah.
This is kind of fun. All right. Starting off with our personnel report, I actually have only a very brief personnel report for you this week. And I also wanted to just mention that going forward, starting in February, if it's okay with the board, I would actually like to incorporate the personnel report into the written reports for your review prior to the meeting. And that way I can utilize this time up here to give you reports on things that are happening within the community and within the department that are not as regular as those personnel reports. So if you are all okay with that, I will start incorporating that into those written reports. That being said, we have not had any new hires this month, but we have been working on some hires that came in late December. We don't have any promotions or transfers this month. We did offer the vital statistics clerk position when Ron retired, and that has been accepted, and that person will begin in February. We do have some vacancies, as you are well aware, and we are in process on several of those. So the STI epidemiologist position, I believe, has been filled. The WIC clinic nutritionist position, currently we're in interviews for that position. We have a community health planner 2 position for which we are currently interviewing. The deputy director position, as you know, we went through the process. Unfortunately, the candidate that we chose didn't work out, and so we reopened that process. We do have several good candidates, and we are working on scheduling interviews right now for that. And then we have an EHS 2, Environmental Health Specialist 2 position in our food safety program, and that will be filled internally. That typically has been a promotion opportunity for our large group of EHS 1s as they grow and develop when one of these positions comes open. And so we'll fill that shortly. And that is all I have for personnel. Does anyone have any questions on that? All right. The second thing that I believe we are going to talk about, and hopefully my computer isn't going to die on us while I'm talking about this, but just a quick update on COVID. I'm not going to bring up the dashboard right now because literally my computer is going to die here. Currently, our COVID level is at low. Our community level is at low. We're sitting at 58.8 cases per 100,000 for a 7-day total, and that has been trending down slowly after we had a little bit of an increase for a few days. So that's good news. However, we know that we still have kind of this trifecta of respiratory illnesses happening in the community. So we still certainly are cautioning people to be careful and mindful, to stay home when they're sick, to practice really good hand washing, to wear a mask if they are going to be in a crowd. If they know they've been sick and they're just getting well, to put on a mask so that they're not, spreading it when they do go out, and just to be mindful. So influenza, RSV, and COVID, of course, are the 3 big ones that we're worrying about right now. Influenza also is on the decrease right now, but we still have plenty of cases out there of flu. By no means does that mean that the flu season is over. This is likely just kind of one of the dips on the roller coaster. Typically, we see another good wave in late winter and spring, so that could come earlier or later. We don't know, but it's certainly still out there, still plenty of it, and we want people to be mindful of that. Also reminding people that vaccines are still available, and we still highly recommend that people get their COVID boosters if they haven't gotten that, and also to get their flu shots if they haven't done so. All right, that was my very, very brief Douglas County COVID update. I also wanted to remind you that we are working on an update to our dashboard. So it's close to being completed. So hopefully next month I'll have that to show you. But basically what that will do is highlight those 3 big respiratory illnesses that we're tracking. So you'll be able to see, and the community will be able to see with a little bit better accuracy kind of where we sit with all of those and what the overall disease burden in the community is looking like with all of those respiratory illnesses. So that will be coming shortly. I also wanted to give you a brief legislative update this morning, knowing that the legislative session is well underway. And there are quite a few bills that have already been introduced that could impact public health that we are tracking. I believe today is the last day that bills can be introduced, and I don't know, honestly, how many more that would be impacting, for public health that we will see come forward today, but certainly we're keeping our eye on that. I would love to highlight just a few of those for you. First of all, LB 421 is one that we are keeping our eye on, that we're a bit concerned about. It accomplishes some of the same things that the city code changes here in Douglas County accomplished last February timeframe, or whenever that occurred. Would do that for other health departments that are larger like ours. However, it also appears that it could limit those more targeted DHMs that would come forth just for, when you have a localized outbreak of something happening, if you would need to issue a very targeted DHM to a small handful of people, this legislation would impact that. So we have some concerns there, and we're watching that. There are also a couple of bills related to food safety. One of them is to update the food code, and would also take away the requirement for inspectors to have the registered environmental health certification, which is something that we would not support. We want to see that certification maintained. At Douglas County Health Department, we give our employees, if they don't come in with that certification, we give them a few years to get their inspections under their belt. You have to have a certain number of inspections that you've done in order to be able to sit for that certification. And so we help our employees work toward that, but it is something that we expect that they will sit for eventually. This would basically take away the requirements for any health department to have that for their staff. My understanding is that it's been very difficult for some to hire inspectors with that certification. Of course, as you can imagine, that speaks to standardization of how inspections are completed and ensuring that best practices are being met. And taking away that certification would mean that we have less assurance of that. We could still require it at Douglas County Health Department, but when you think about other agencies that are completing inspections, we wouldn't have as much assurance for the inspections that they're doing. So that's one of the ones that we're concerned about. Another one of them would impact how the mobile food trucks are permitted. So we have a number of food trucks that kind of cross jurisdictions. They may operate in one county and then come into Douglas County, or maybe they're a Douglas County food truck and go into another. That basically, the legislation that's out there is basically to make it easier for our food trucks to cross jurisdictions, which in general we support. There are some things in that bill that we would like to hopefully talk about before if it moves forward. We also are very happy to announce, and Leah, hopefully I'm not stepping on your thunder here. We're very happy to announce that Senator Vargas introduced the bill that we have been working on that would enable us to do overdose review on teams, very similar to how FEMUR, or fetal infant mortality review, teams operate. This would essentially mirror that process for opioid overdose deaths, and we are very excited and happy to see that bill get introduced, and hopefully we'll see that go forward and pass so that we're able to do a really good deep dive into those deaths and do a better job of targeting our interventions toward prevention of those overdose deaths. So we'll be very happy to watch that one. And then we do have a request, I believe. Is it 75? Okay. I don't know a lot about LB 75. Leah, if you don't mind, would you mind just kind of giving a very quick brief on that and the ask?
Good morning. So LB 75 is also being introduced by Senator Vargas, and it is the maternal morbidity review. So also similar to FEMUR overdose, but they have requested a letter of support from us to basically just support the maternal morbidity review. It is not requiring us to do anything. It's not requiring the state to do anything. It's just putting that bill out there so that when funding may come down, we'll be able to actually do those review teams similar to FEMUR. So that would be the request, if we could do a letter of support. Cool. Awesome. Thank you, guys.
Great. Thank you. I'm sure that as we get deeper into legislative season and bills have started to actually undergo hearings and move forward, I will have much more to report for you, but I did want to just give you a really quick and brief update on a few of the bills that are out there that we're keeping our eye on. So more to come on that. Does anyone have any questions for me at this point?
On those middle two that you mentioned
LB 421
okay.
is the one
You got
that
you
would
got
change
one. You mentioned the two middle ones. You didn't give a number on.
the food. Yep. Let me see if I can find them on here quick. I have to admit to you, one of my big weaknesses is remembering bill numbers. I'm terrible at it. If Dr. Figs is on and remembers what the bill numbers are, he can sure pop in and tell
Is
us.
there,
But
Dr. Figs, you got that number offhand, by chance?
I do not.
Okay. Well, if you wanna just get it to us, Dr. Hughes.
yeah,
we can
I'll
go
do
from there.
that.
Yep.
Yeah, there's quite a list of bills at this point, so I will get those numbers for you before we finish up today.
Then you do have a question from Councilman
right.
Festus.
Thanks, Mr. Chairman. Lindsay, on LB 421, I haven't had a chance to read it in its entirety either, because there are lots of bills coming, lots to review. Do you know if it's entirely consistent with what the city did, or would it require changes if it was passed?
Chris, you read it yesterday too, so you may be able to pop in on this, but it's pretty consistent with what City Code accomplished last year. But it wouldn't impact, that piece would not impact Douglas County Health Department right now. Honestly, it would impact Lincoln Lancaster County Health Department more. However, there is language in there that does not seem to give the same amount of leeway around those very targeted DHMs, which I remember testifying for quite some time before City Council about the importance that we be able to issue things like isolation orders, to individuals in certain circumstances. For instance, if you have somebody with tuberculosis who is non-compliant with isolation, we need to be able to issue a DHM to that individual to isolate without having to go through multiple channels to do so. It's my recollection that was something that the City Council was in support of, allowing that kind of flexibility. It was really more an intent to have more input when there was a large DHM that impacted everyone in the community. So this bill would, again, narrow that capacity for us to be able to issue those individual DHMs without basically having to go through the state, the City Council, or the county board, which would be detrimental when you're in an emergency situation where you need to get someone isolated or quarantined very quickly.
So, Josh, tell me, because he's got something, but this is my interpretation. So, when I read it Friday, that's when I said you probably need to look at it, because it looked like it's two sections. It's like the Lincoln Lancaster section, and then there's everybody else that's created under law. And it took a direct shot at Lincoln Lancaster. That's where they were trying to close that loophole. But there's other stuff written in there that, to me, I don't understand if there's some inadvertent effect, because some other changes she made makes the language inconsistent. That's my interpretation.
Thanks,
As a
Commissioner.
non-lawyer.
Yeah, Josh Wolf, County Attorney's Office. They really target two sections of statute in LB 421, 71-1630 and 71-1632, I believe. I don't have it in front of me. The first section of statute that they target is the one that deals specifically with the Lincoln Lancaster Public Health Department. That is a unique situation in the state where you have a county with a population over 200,000 and a city-county health department approved by DHHS. I believe it's the only one in the state. And they make changes to that code with regard to the ability to issue DHMs. What they don't do, that the city council change did do, is differentiate between types of DHM. The city code change dealt directly with when the city is affected by an epidemic or pandemic, and those types of DHMs. This legislative change does not make that distinction, which is an important difference between the two. This legislative change also doesn't have some of the timeline components that the city ordinance change did. So with the city ordinance, for instance, the director would go to the mayor, and the mayor would have X amount of time to act before the process continued without the mayor's input. None of that is contained in this legislative change. And so it could potentially hamstring a public director's ability to act. The other thing that the statute change does is change the powers of a health director. And that would be for any health director in the state. And it, in my opinion, attempts to incorporate some of those changes that they're making to 71-1630 without effectively going back and making changes to other sections of statute that define a board of health or a health department's authority under other sections of code. For instance, this board's power is not as outlined in 71-1630, but the code attempts to impute those changes to the health director by changing the section that deals with the health director's powers. And it also does not include those timeline issues that I just discussed with regard to how a DHM would play out, nor would it differentiate between a citywide, countywide DHM or a targeted DHM to an individual or small group of individuals. Does that answer your questions?
Yeah. Complex as always, right?
He's so good at that. All right, any other questions at this time? Yeah.
Just for clarification, DHM, Department of Health mandate?
Directed health measure.
Directors, thank you.
It's essentially a,
Sorry,
essentially a mandate.
directed health, thanks.
Is it possible you can just send us a Word doc of the various bills that you are watching?
Happy
That-
to.
Okay, that'd be great.
Okay. With that, I think I'm complete.
Thank you, Dr. Hughes. We're moving on to item 6, which are presentations for the month. And in the continuing effort to reconvene the series that we had usually done before the pandemic in regards to getting an understanding of what the entities are doing with the community health benefits. We're honored today to have UNMC, so we'd ask them to come up and talk through their presentation on their community benefit. Welcome.
Thank you. Should I share my screen from this? Okay. Exit. Missed the button. Try it again. Good morning. Thank you for having me. I'm Becky Jackson, Director of Community and Patient Engagement for Nebraska Medicine. I do want to acknowledge my medical director and partner is Dr. Jones. I have the privilege of working with her on a daily basis in this work, so thank you for your time here. I was looking back and wanted to give a couple things that we wanted to walk through today, really thinking where we were in our timeline very briefly. I know from my time on our 2019 to 22 CHIP, and then we're starting our 22 to 25 Community Health Improvement Plan. Some quick updates on our health equity work and a quick community benefit update. It's going to be a quick 20 minutes. We'll get through as much as we can. Do want to acknowledge that while we are partners with UNMC, they are the academic medical side. We are the clinical operations. So representing Nebraska Medicine today, just wanted to clarify that. When I speak to Nebraska Medicine, that is our 2 hospitals and our clinic ambulatory operations of over 88 clinics across town in a variety of specialties and subspecialties around primary care as well. I was looking back and it made me chuckle a little bit. The last time I had the opportunity to present to this group was in December of 2019. So we had no idea what was coming 3 to 4 months down the line. And so in terms of what impacted our 2019 to 22 CHIP, we had a couple of things going on. We have, I think we are actually, in terms of the health systems, the last in the timeline. So we had our CHIP approved in November of 2019. Came to this group to provide some updates a month later, and clearly had some COVID impacts over the next time. Well, I'm very proud of the impacts that our system was able to have. Regardless, I just would be remiss to not acknowledge the significant influence of that impact over time. So while there are more updates on the slides than I have time to present today, I'm just going to call it a couple of highlights in relation to our 3 needs from our last CHIP were access to care, injury and violence prevention, and mental health. One of the key things that we talked about was really expanding that access. So we look at things like our immediate care clinic strategy, expanding sites to be Southwest, Northwest, Midtown, and Bellevue, with increase to look at that and some impacts we'll talk about here. Really one of our key focuses is talking about our patient-centered medical home approach, where patients come to our clinic settings and get access to all different accesses of care. So behavioral health is in those settings, access to resources and social needs as well through our referral process and our social work team. So increasing that and continuing to enhance that. Telehealth services was a key component in terms of access, especially over the last 3 years. But some of the things that are continued to be planned in this space, we talk about expansion of our Fontenelle Health Center. COVID did delay some of those impacts that were planned, while that is now getting in progress, and pending provider recruitment, anticipating some immediate care exposure and planning there as well. In terms of some of our injury and violence prevention, you may be familiar with some of these programs. Just going to speak on a couple of them that are newer. Continue with our violence prevention programs, both within the hospital and outside of that setting. Specifically in Dusk to Dawn, our hospital-based youth violence prevention program. It's a real community partnership between our system, Omaha Police, U-Turn, Boys and Girls Club of the Midlands, really thinking through how we can help youth to really expose them to the physical and emotional consequences of violence as that catalyst, thinking about the values and emotions and problem solving that they can learn through that program. Stop the Bleed training is a trauma intervention program. One of the key tactics over the past 3 years was to ensure that even more of our colleagues were trained in this tactic to be out in the community and be able to provide that resource, as well as community-based programming. And then a new collaboration within our emergency department trauma team, and again, partnering with U-Turn, is Encompass Omaha, really working to mitigate potential acts of violence or retaliation for patients and families. So an intervention program helps individuals to recover from the physical and emotional trauma, ultimately reducing violence within our community, connecting those participants to supports such as housing, mental health care, legal aid, and job training. And last of our 3 priorities from the previous cycle was on mental health. Many things that happened in this space. I'm going to call on a couple that are featured here, really wanting to increase the number of mental health practitioners that we have available to see patients. We see that as the greatest need and the greatest gap. So making sure that we have specialty care to increase our availability. Several psychiatry subspecialty clinics that were developed. Our behavioral health intensive outpatient program provides integrated care for individuals that are balancing between addiction and psychiatric disorders, and so really helping to support that particular need. And then I think, as probably has been publicized pretty broadly, is our opening of our psychiatric emergency services unit, which happened during this time frame. It's a separate unit outside of our emergency department to really provide a calm, compassionate environment for stabilizing individuals before getting them to a more appropriate referral base. And then finally, our community-based program is our Behavioral Health Connections program, which continues to enhance their opportunities for patients and individuals with either psychological or substance use disorders to area resources. So again, really making sure that we're capturing the full needs of that colleague, so available resources, transportation, prescription medication programs, et cetera. That was the very quick version of what happened in terms of kind of where we straddle the update here, but wanted to move into our current process. So again, our timeline is a little bit different from the other health systems. We had our community health improvement plan was just approved in October. So we are starting our phase, and we will be moving into 2025 with this. But from that community data survey, and appreciate the opportunity to partner with the local areas on that data, as a system, we prioritize these 4 needs that you see: diabetes, mental health, nutrition, physical activity and weight, and prenatal health and infant mortality. Really, the methodology that we used was to see a stronger focus on priorities that arose from the community, and to look at those that represented differences across our area of service, so where there are differences and a greater need, in alignment with our diversity, inclusion, and equity goals, which we'll talk a little bit more as we continue. So our process here, we have action teams for each of these priority needs that are within our system. They've just started meeting. And so while we put together that CHIP and the high-level goals, those teams are helping us to craft what some of the specificity is between those implementation activities and how we continue that. So I'll provide some of the high-level goals and can answer questions on kind of where our direction is for some of that, but just know that we are early in that phase of our work comparatively. So in terms of diabetes, really thinking through how we can expand our community education opportunities related to prevention and care. So we're talking about really looking at pre-diabetic and diabetic patients in this, helping to test increasing our community-wide screening strategically to support the community in addressing these needs. So point of care A1C testing in the areas where it's of greatest need. Thinking about community programs that can implement prevention strategies, additional community collaborative projects as we think about what are those treatment options around diabetes and weight management. Obviously some similarity here in this particular need along with our nutrition. And then really thinking, how do we support healthier food options, access to fresh food, healthy decision making through all spectrums of service. Obviously some clear community partnership will be happening in these areas too. Our next one in terms of mental health, continue with our goal of increasing the number of health practitioners both within our system and those that we provide access to and exposure to within the community. Really important to us to have culturally competent and trauma-informed providers. So we've started that work. Want to make sure that that is across the entire system, understanding how our practitioners are able to support our community. Thinking through that co-occurring mental health and substance use problems, making sure that those needs are being addressed even more than we have the capacity to at this point, so increasing that capacity. And ultimately, decreasing the stigma associated with mental illness or disorders through communication, education, and community awareness. So participating in community collaborative projects that also leans into our social determinants of health work. We know that's an important key here along with our other needs. Enhancing that behavioral health connection program that I mentioned earlier. And really, in our terms of our system, looking at some of those gaps of how we can make sure that our referral process, both internally and externally, is really working efficiently. In terms of nutrition, physical activity, and weights, again, that crossover with healthier food options here, increased awareness and direction around food insecurity within the Omaha Metro, looking at those community-based organizations and support of them, partnership with them throughout the region, support food security. And then from the physical activity perspective, community involvement in a variety of options there. So really looking at the data, we want to make sure that we're also supporting this internally. So for our employees that need access to these resources, that is a little bit more defined, as well as evaluating and implementing and moving forward with physical activity programs, both within and outside and within the community. One of the big pieces that we are focusing on is how we do our SDOH, or social determinants of health screening for our patients, and partnering through that work is going to be a key tactic for this 3-year cycle. I'm making a lot of progress there, and so hopefully have some great updates the next time that I'm back. And then last, we categorize this a little bit differently than I think was listed in the community data. We are capturing this one in terms of maternal health, specifically around prenatal health and infant mortality. Again, that increase of culturally competent and trauma-informed providers will support this work as we understand the impacts that we are having, destigmatizing the normalization of adverse outcomes for maternal and infant health, and then increasing access for preconception care and prenatal care visits within that first trimester of pregnancy. So looking at opportunities within our system for expanded visit templates or alternate care models to address those issues and concerns, but really listening to the voice of our patients and the community on their needs, addressing these issues and supporting really the opportunities to care for our families and making those changes in an appropriate way. I want to segue a little bit. Those are our goals. Again, just acknowledging that we are early in that process of our CHIP work, but there's a lot of alignment with our health equity work that is also happening. So while I am not on our DEI team, I have the privilege of working with them. Our diversity, equity, and inclusion team really stood up close to about 1.5 years ago. And so there's many things that have happened as they continue to grow and expand. One component of that work that segues with our community health work specifically is our Health Equity, Diversity, and Inclusion Council. Not to throw a lot of acronyms at the group this morning, but there are 2 subcommittees within that, our Climate and Experience and our Equity of Care. And so our Climate and Experience group really looks at workplace culture related to these efforts. So some of their priority tasks include things such as expansion of our employee resource groups, diversifying, hiring, and retention of a community representative workforce, some of the key tactics that they're looking at, and then partnering specifically on that trauma-informed culture. So there's a lot of overlay, and really just sharing that there is consistency throughout multiple levels within our system. So equity of care, I have the opportunity to co-chair that with my colleague Shonda Ross. And so our equity of care team really is looking at that intersection of quality, safety, and equity-based care across our system. So we are looking at multiple data sources, really thinking through, how do we look at populations to anticipate patient needs in relation to culturally effective care, system-wide SDOH screening, tracking, and referrals, how we report and how we get our patients to report real and SOGI data to strengthen their outcomes and to allow us to understand where our gaps and opportunities are. And thinking through how we get feedback from our patients and the community, because we know that we are experts in some things, but we learn, and that's our most important component here. I'm not sure if any of my other health system partners have acknowledged, so I wanted to call out here too, that we are also starting to see Joint Commission and CMS requirements around health equity, health disparity screening. So that's clearly on the mindset for everyone within our system and our partners as well. But thinking through that is linked to a quality and safety priority. I'm extremely thrilled that those regulatory requirements are coming because they are giving us a platform and so giving us some of that strength behind that conversation while we've been doing some of that work, knowing that we have expectations and outcomes and standards that we will be meeting here in terms of equity and looking that we have a strategic plan of how we're going to advance healthcare equity both within our system and the community is really important, and I think will support our work that we have going on here very nicely. Segueing a little bit into our community benefit, we provided updates about our community commitment in the past, pulling the last 5 years. Our timeline here is always a year behind, so this is our July of 2020 to June of 2021 is the 21 community benefit numbers that you see at the last. We have continued to see those increase year over year, and I'll break those down here on the next slide for what that 21 commitment specifically looks like. So seeing some of those components, our largest thinking through that uncompensated care component, the broader community health, and the community building activities. Our community building activities, acknowledging that is lower in years past, that was a key COVID impact. So less opportunities that we could be in some of those areas doing some of those community building activities because of restrictions on that end. So looking at some of the components, and happy to answer any questions that may come up, but uncompensated care in terms of our financial assistance or unreimbursed Medicaid expenses to the system. Broader community health really goes from a variety of cash and in-kind contributions through our education, our components in support of our academic medical center, some of our subsidized health services in terms of clinic support across the community, and research and operations. With that, trying to keep it on time, I will open for any questions.
Any questions?
You mentioned work on a sort of a questionnaire or standardized intake that you would ask of clients in any of these situations. What I'm getting at is thinking about public health from the social determinants and wondering if we are, when clients come in, well, you are, asking some basic questions about food insecurity, about their safety in their environment, about where they work, where they live, where they play, just general questions, and then trying to address those related to diabetes, nutrition, prenatal health, et cetera. Do you have transportation? Is that an issue? Is that something that people are working on?
Yes, that's the goal, absolutely. And so we have some pockets of areas where that's happening now, trying to get it more system-wide. So we're seeing it more in our ambulatory setting, wanting to make sure that that's across our inpatient, our ED, and all areas, to ask those questions about transportation, housing, and food, and then most importantly, making sure we connect those individuals to the resources. We don't want to just ask the question and not do the follow-up work. But it is not 100% across system right now. That is the start and where we're going. Yeah, great question.
Go ahead.
Thanks, Mr. Chairman. Just two follow-up questions for you. So the largest portion of the community benefit number in 2021, $193 million of cash and in-kind contributions. Could you just talk about that a little bit more? I wasn't sure I understood what that represented or.
Absolutely. So really, as an academic medical center, the largest
Can
community
you put the
benefit.
slide back up, because I'm gonna ask you about
Yeah.
that? Because
Absolutely. Yeah.
Yeah.
So this broader community health section and the cash and in-kind contribution. So this is really our largest community benefit that we see is the support of academic programs and operations at the University of Nebraska Medical Center. So as our affiliation with that group. So that's where we'll see a lot of these numbers come from. So we provide the clinical teaching environment for all the students at UNMC and mostly with Clarkson College as well. So that's a big part of our mission. So making sure that there are work in that space is where a lot of this is going to come from. In terms of some of the cash and in-kind contributions, thinking through grants for operational support, our charitable contributions, and in-kind donations of goods and services to other 501c3s is what falls into the cash and in-kind components.
So it's a combination of grants to
It is.
local nonprofits, but also investments in training and academic affiliation. Is that
Correct.
okay? Is there a breakout of that approximately? Those two things?
I don't have, I didn't bring the whole tax report with me today. I apologize. I just brought the summary report. I can find some of that information and send it in follow up on what's here.
That'd be of interest to me. And then second thing, I think in your remarks you also sort of noted maybe a shift in focus from the last 3-year program of work, which I think was access to care and injury prevention and behavioral health, to things like diabetes and mental health and then your nutrition and prenatal health, all of which I think are very important. But would you describe that as a shift in focus a little bit, or what are you seeing in the community, I guess is my question.
Yeah, I think that our strategy this time was to pull from more of those priorities that came at the top of the community needs. And so previously our approach had been really thinking through what our internal priorities were. So injury and violence prevention, cancer has been a previous one. Access to care really continues. Access and social determinant of health screenings and components are going to be embedded throughout all of these. But really wanted to listen to that voice of the community, and so picking more from that top of those prioritized needs in terms of diabetes, nutrition, physical activity, and weight in particular. And our acknowledgement of prenatal health is our take is that perhaps we need to share the message about why that's such a concern within our community and getting that component in terms of education out there. I think that would be a higher need from the prioritized list, if so. I think we wanted to think about the areas that we could target across all areas of our system too. So primary care in particular is one of our stronger components, and that these are issues that can be addressed through that cycle. So patients can be screened and discuss diabetes and pre-diabetes interventions in that primary care setting through the entire inpatient experience if necessary. So a little bit of a shift, I think more of a public health approach around some of these definitely has been the key for our upcoming cycle.
Anybody else?
There are a couple of questions.
Yeah, I got them. I'm gonna ask them for them right before that.
Thank you. A couple of questions in regards to mental health. It's very important, and you've highlighted the needs of the community within mental health resources, but I was concerned in regards to internal resources for your staff. Post-COVID, that has been one of my goals, to really see what the health system and how they're supporting their staff. Can you give us some examples of the benefits that you have internally for your employees in regards to mental health?
I think that's one of our strengths, and not one that I called out today, so thanks for that question. We have had through the start of COVID a peer resource connection, so that if a colleague is having anything from a difficult patient experience to a difficult personal experience, they can get a recommendation and get support from behavioral health colleagues that day. So reaching out to that colleague, getting support from them, and then triaging if they need to get additional or expanded service. Our access to behavioral health support for our colleagues is strong through our EAP and other programs too, but we have multiple teams that are out to support our colleagues on an individual or team basis as well, so that if there's a challenging situation that comes up in a care environment, that can be addressed and then followed up. But we acknowledge there are still things that we are learning through that COVID pandemic. There's been a lot of impacts to our staff. I think we're seeing that more in terms of recruitment and retention. And I think that is something that will be an ongoing challenge for all healthcare systems as we look to expand these services, having the staff and colleagues there to support. And so I think that is a direct impact of the pandemic.
You want to ask it?
Yep, I can do that. So we have a couple of questions from one of our board members, Dr. Kiana King, who's online.
Okay.
She asks, first she says thank you for your presentation. How do you decide to spend the community benefit money? And is there like a proposal request process or some other process for that?
Great question, and good morning, Dr. King. So when we think about our sponsorship requests, we do have a formal process. So it's posted on our website. We ask all 501c3s or organizations to follow that standardized approach. We have a committee that reviews those. So it's everything from, we look at some of their financial impacts, what their goals are, who they're connected with within our system, who their board members are. And then we have a sponsorship committee that reviews those requests to see if they're in alignment with our needs, our priorities, and if they're for the greater good of the community.
Excellent. Her next question is, she noticed that the HEDI is doing work to establish equity in care. Are there also plans to establish equity in access?
That's a great question. So we actually in our first work with Equity of Care and our HEDI Council overall had an impact assessment that was completed. So our priorities are thinking through, and again, I think I called out defining those at-risk populations, then understanding from there where those components are of challenge. So is that an access issue? Is that a specific concern in having that care opportunity? Are there other things that we need to address? And so this is really the start of understanding. And we have some external data that we can use. We want to validate that internally to make sure we're able to address the appropriate groups. And I think access is a key component across all of the concerns that we're discussing today.
Thank you. Her last question was, she noticed that, or she was hearing your plan to increase the number of health practitioners for mental health, and she wonders, what are your plans to ensure those hires are diverse? There's a gross shortage of practitioners who are people of color.
Completely agree and acknowledge, and that is one of our key components. So where we can find access to, is that within our system, is that access for our community members to find diverse providers in a number of ways. So we think about telehealth services and other access, but it is one of our key goals within that we need to address. We actually just had our group meeting yesterday, and I think it's a challenge both from a recruitment, again, and a retention. And so we're finding that in that behavioral health, mental health space, providers aren't staying within that system and that role. And so we're seeing about a 2 to 3 year cycle was what was shared yesterday in terms of having to think through rehiring. So it's an ongoing challenge, not just in our nursing and medical care, but especially in our mental health. But for us, a key tactic of that is making sure that we have representative providers for our community.
Okay, let me ask you, so I want to make sure you gave, I wrote down from the 21 plan, some of the things like Encompass Omaha Psychiatric Emergency Service Unit. And so I'm assuming the emphasis that you put there for 22, those 4 points, and the teams that are centered around that, they're still in the process of recommending specific actions like Encompass Omaha, and at some point they will do that.
Correct.
So I'm assuming like when you all come back next year, you will be able to report out what that group says is going to be the specific stuff that goes for that.
That's correct.
Okay. So can you go back to your slide of the one that listed the years of numbers?
This one?
All right. So this is my question that you had Children's, and we had Children's come. They're kind of separate from you all, Methodist and CHI. So you're gonna get the first question from the hospital system. So I'm just curious. So 18, Medicaid expansion passed. In 19, everybody had to work their way through and things of that sort. I'm just curious, is the increased numbers, is that increased number trend recommended, is that increased number trend reflective of decisions made because there was more money available through Medicaid expansion, or did the CARES Act and COVID monies that you may have gotten, or the money you got through the Fed, did that give you more room to do stuff in there with that number growth?
Well,
I'm just curious.
my understanding from our finance team when we pull this, and it's obviously a partnership to pull this component together, is that anything that was associated with CARES that was
Okay.
paid for elsewhere is not captured here because
Got
it's
it.
not community benefit.
Wanted to make
So,
sure.
yeah.
So could I say the number reflected from 1920 well, I guess I'm just curious too, because I don't want to measure you all on a scale that's unfair because of everything going on with COVID to some degree. I'm just curious in 20 and 21 particularly, that you weren't in the traditional giving cycle because COVID was overwhelming anything. I'm assuming most of that was food, other stuff associated with helping patients and everything get through the COVID piece. So it may have it has some alterations, I guess, to do with what that 18 to 21 plan was. And I just want to make sure my expectations are when I ask you all the question next year about whatever that group comes up with, what those recommendations are going to be for 22, 25.
Yeah, unfortunately, we're just really early in that process.
Yep.
So just had that full plan approved, like I said, in November, really thinking through. We put together that broad expectation of where we want to see those goals, and that's been approved by multiple groups across campus, as well as we just started we have a new community engagement committee at our board of directors level with community feedback, which we're excited about, really having their investment and commitment to this work too. I think it'll be really interesting to see as we're pulling together, and we'll have our 22 community benefit report by June of this year. So I think it's just thinking through as we're still trying to see the impacts of COVID across all of these numbers.
Okay. I'll be curious to see that. Okay.
He made me think of a follow-up question. Since Medicaid expansion, have you still seen your uncompensated care grow each year?
Yes.
Yeah. And then one thing I know we're all watching that is of concern is Medicaid redeterminations that'll happen starting in April. I know in Nebraska, during the public health emergency, folks were not kicked off Medicaid or Medicaid assistance, but that's ending pretty soon. And so that could affect tens of thousands of Nebraskans coming up this next year, and certainly hospital systems too that are in that space. So something we need to keep our eye on, I think.
Absolutely, and making sure that we have those that are eligible connected and know how to access those programs.
When does that start again?
April 1st.
Okay. All right. Noted. No other questions in the chat? No others up here? Go ahead.
Had one more question. Going back to the prenatal health piece, and you had I don't know if it was a goal or objective, but I just wanted to unpack exactly what this means a little bit. Destigmatize the normalization of adverse outcomes. Can you just speak to what that's referring to?
I think, we know that there are stark differences between members of our community, and both from a maternal health and infant mortality statistic-wise, and we do not know that message has been shared. So part of our advocacy is creating awareness around those differences. Okay. And I think, if I believe correctly, and when we looked at the prenatal health and infant mortality on that prioritized list, it fell to like lower half of those prioritized needs. We know that there are significant differences, and we know the impact that has not only on our moms and babies and birthing individuals, and making sure that sets the stage for a healthy life. So really, it's just it's an advocacy component, both internally and externally.
Okay, thank you.
Okay. I think we're good. As I said, thank you, and I'm interested to see how you all's plan grows from the last time you came. So I'll be looking out there to see what happens.
Thanks.
Appreciate
Thank
the
you.
time. All righty, with that, we'll move on to the next presentation, Presentation B, which will be Charles Drew Health Center. Last month, we did have a presentation from One World to to update on that, so I think Kenny is on. I don't know if there's anything we need to do on our end. Just open disclosure, I am a member of that board, of the Charles Drew's board, so with that, we'll turn it over to you, Kenny.
All right, good morning, members of the Douglas County Board of Health. Thank you all for having an opportunity to give an update on all things that are happening here at Drew. I will say I'm having some technical difficulties here, so if I happen to cut out, I'll try to get back on. But I am my name is Kenny McMorris, and I'm CEO here at Charles Drew Health Center. And just by a little context, we're one of 7 what is known as federally qualified health centers here in the state of Nebraska. Charles Drew specifically is the oldest FQHC here. And so we are in the business of health maintenance and prevention. And so we have the pleasure of serving nearly 13,000 patients, accounting for roughly about 40,000 encounters in medical, dental, behavioral health, pharmacy, and what we call enabling services. And many folks may know that as a lot of the work that happens with the community health worker. So we do that for the broader North Omaha community. We have 13 service delivery sites. We have the pleasure of working with Omaha Public Schools and providing school-based health services, and specifically 4 school-based health centers. The Omaha Housing Authority, we have actually clinic locations located in 4 of the Housing Authority towers, where we do a lot of screening, a lot of engagement with the individuals with the Housing Authority. And then we also have mobile units, mobile medical, as well as a mobile dental van that allows us to get out into the community to really try to alleviate challenges with access across the board. So that's kind of our portfolio. Demographic-wise, about 77% of our patients are 100% or below the federal poverty level, and that's roughly about $26,000 a year for a family of 4. We take and we provide services to everyone regardless of their insurance status. So you can either be uninsured, we take commercial, we take Medicaid, as well as Medicaid beneficiaries. And we offer a sliding fee scale. So every patient that seeks our services would be eligible for that sliding fee scale. And based on where they are, family size and income will determine cost, if any, related to accessing our care. We're part of the bigger healthcare delivery system. I think we just got a presentation from Nebraska Medicine, but we are provide outpatient services. So we really rely upon the support of the broader health systems to ensure that members in our community are reaching optimal health. And so, again, getting back to the business of health maintenance and prevention, we are Joint Commission accredited for ambulatory care, and we have this past year received accreditation for mental and behavioral health services as well. So really focusing on making sure that people in our community get the mental and behavioral health services at the right place, at the right time that they deserve. And we all know a lot of the stigma that is associated within the community and accessing in that care. And so that's why representation matter, I believe, making sure that people have an opportunity to see folks that look like them, to help advance and make sure they're getting and feeling comfortable and feeling safe in those environments. And so we try to do that every day in the work that we do. The federal government has what they call special designations for special populations. You can either be a base community health center, there's a migrant farm worker designation, as well as individuals that are experiencing homelessness and residents of public housing. Charles Drew has that 2 designations that of distinction, one for public housing residents as well as homeless residents. And so this past year, we served roughly about 2,000 individuals attesting to homelessness. And so, again, we received that additional support from HRSA and the Bureau of Primary Health Care to make sure that individuals that have complex medical needs are getting the care that they deserve and what they need. So very proud of the work that we're doing in that space. And most recently, we launched a partnership with Sync Health, Sienna Francis House, actually Common Spirit and CHI to look at a medical respite programming for individuals that are experiencing homelessness that have been recently discharged from the hospital, but for all intents and purposes are probably still too sick to not receive care in a coordinated way. And so we launched that program back in August, I believe. And been able to, while it's a pilot, we've been able to glean some pretty good, some lessons learned, and hopefully over the next couple of years, we'll continue to address medical needs for those experiencing homelessness in a more meaningful way. I would be remiss if I didn't mention our Omaha Healthy Start programming. Charles Drew's been a federal awardee through the Maternal and Child Health Bureau of HRSA to really address infant mortality. We know the numbers are pretty bleak when you look at East Omaha and specifically North Omaha as it relates to women accessing healthcare, babies getting the prenatal care that they deserve. And so our Omaha Healthy Start program is a way to try to address those needs. Over the last year or so, there's been a movement afoot nationally, and we're starting to see more here locally, of support services for what is known as community doulas. And really, these are advocates, these are individuals that are certified and trained to help support the process of birthing women to ensure that they get the connections and support that they need as they go through their journey. So we're really excited about being able to receive additional resources, not only from the federal government, but even here locally through some support from the United Way and other partners to partner with a group called Ivy Black Girl. They've been able to make some significant investments in the community related to doulas, and we're looking forward to continuing that relationship with them. Additionally, the county, we work with you all on WIC programming. And so Charles Drew's been a WIC site since, actually, that's how the community health center actually started here. Ultimately, we were providing WIC services, and we continue to do that in partnership with the county. And so, again, really addressing a lot of those social drivers and social determinants of health in terms of food insecurity, and making sure we're doing it in a coordinated way with our practitioners. Finally, I'll hit on our justice-involved work. And we know that individuals that are tied into or part of the criminal justice system, one of our gaps is being able to make sure that they have continuity of care and services. And that ranges from physical health to mental health. And so a few years ago, in partnership with Douglas County Youth Center, Nebraska Medicine, and CHI, we launched a program to provide services to young people that are temporarily housed within DCYC. A lot of it is screening and assessment with the hope that upon release that there would be a level of continuity of care and services that are being provided to them. And so over the last few years, we've been really working that program with a number of different partners, actively involved with probation and other folks to ensure that we tie what is happening in the criminal justice system to overall health care. I think that when we look at the stigma associated with mental and behavioral health, trying to do everything we can to decriminalize those that may be going through the system, and recognizing that we are dealing with systemic trauma, making sure that those young people get the services they deserve in a setting that's comfortable is really what we're hoping to try to accomplish on the front end, and then make sure that they get the coordinated care on the back end. So ultimately, we look at all of these things. Obviously, we've been dealing with COVID, and I like to tell folks that we're just in a different phase of the pandemic. I don't believe as a community the dealing with COVID-19 is ever going to go away, but I think we've adapted and become better across systems and coordinating, doing everything we can to work with our broader partners to ensure that people within the community get access to vaccines and to testing, obviously. But the whole goal is to ensure that folks get and identify a healthcare home. I think that unfortunately, many folks in our community seek healthcare services episodically, whether it's in the emergency room and other places. And we know that that is, from a cost standpoint, is the most costly point of care. But also not having an established relationship with an individual that knows you intimately from a healthcare perspective creates additional challenges in terms of optimal health. And so our goal is to try to continue to push that to make sure that people know that your health is truly your wealth, and they have an opportunity to get the services in a coordinated way here at Charles Drew and other community health centers that we have in the state. So that will conclude my oral updates. I'll take any questions from board members.
Good morning, Kenny, and thank you for providing an update. And first, I want to congratulate you. I had seen the story yesterday about Benson High.
Yes.
So if you can provide a little bit of context about what's going on there, and congratulations. I know that's a huge need within that community.
Sure. Yeah. So thanks for that question. And yeah, we are excited. So nationally, there's a number of entities that are provide services within schools. And the latter part of, I think, probably around 2009, 2010, there was a movement afoot here locally to look at how could we really start to address academic achievement from a healthcare perspective. And initially started with conversations around mental and behavioral health. And we quickly realized that you got to tie the physical health elements to it. And so Charles Drew and One World, amongst other partners, launched what is known as school-based health centers. And so we have the pleasure of having 4 current schools, Kellum Elementary School, Belvedere Elementary School, King Science Middle School, and Northwest High School. And we will soon have Benson High School added to the list. And so really making sure that we can get connected to those young people in the schools, working with the administration in those buildings and the teachers in the buildings to ensure that those young people get the emotional and physical support they need to reach their academic achievement goals. So we're really excited about it. The model that we'll be operating at that site is uniquely different than some of our other sites. We'll have other community partners, Project Harmony, Methodist Community Counseling, as well as University of Nebraska Medical Center College of Public Health will also be part of the at least service delivery that we'll be offering there. And my understanding is that with OPS really taking these academic career pathways, Benson High School is what is ultimately considered a health pathway. And so I think this will be a tremendous opportunity to get young people introduced to the healthcare field. They'll have an opportunity not only to get the services, but kind of see preventative medicine in action. So that's our goal there, but really excited about it. And thanks for the question.
And just as a follow-up, I am aware that you have the adolescent health clinic that's, just a few blocks away.
Sure.
Is there adolescent health going to be transitioning over to Benson, or is that to be determined, just to kind of see how this, what happens over the next few months until this opens, et cetera?
Yeah, so kind of looking at when you think about the service and the need in that area, both locations will coexist. The Teen and Young Adult Health Center, located is about 53rd and off of 53rd Street in that area, is going to be focused on 15 to 24-year-olds. We know that healthcare for that subset of the population and how they navigate it is uniquely different than probably many of us that are going and seeking services. So we believe that the Teen Center will complement what's happening at Benson High School. Additionally, within Benson, we're going to be providing oral health services. And so within our Teen Center, we do not provide oral health care. So both locations will be complementary in nature, extended hours, and for the most part, give us at least a unique footprint to be able to provide health care to the entire community. 68104 is one of the largest zip codes in the state of Nebraska with unmet need. So we believe that both of those sites should help accommodate a lot of the preventative medicine that we're looking to provide.
Thank you.
Anyone else? Kenny, I'll ask you last question because I asked Andrew this in December, but things hadn't kind of formed. I just asked her what was on the radars for the FQHCs legislatively in the state. So obviously now you've had bill and introduction. I'm just curious what you all's concerns are over the session.
Yeah, so, and thanks for that question as well. I think when we look at all of the community health centers, one of the things in partnering with the legislative branch, we have not received funding from that body since the onset of the pandemic. And so when we think about how do we continue to keep providing the services at the level in which we're providing the services, there's going to have to be, in our opinion, a greater commitment to the community health centers. And so we have asked, and he has accepted, Senator Mike McDonald to champion a bill, LB 108, which would allocate $20 million to the 7 health centers in the state of Nebraska to do 2 things. One would be an increase in our base funding that would go towards expansion of mental health services, as well as augmenting funding for those that are uninsured, and then $15 million that would go towards what we're calling capital innovation projects. And so it would either be expansion at a respective FQHC, workforce recruitment, apprenticeship type programming. And so trying to do everything we can to commit to the workforce. We too are experiencing challenges like the greater healthcare systems. And so we got to make sure, or at least we believe, that FQHCs are an anchor and foundation for preventative health and health maintenance. So we're asking the legislature to help us out on that. The other things to keep on radar, and I think this is an opportunity for advocacy as we look at the work, is I don't think we have a bill number just yet on this one, but we're going to be working on it, is basically 12-month postpartum coverage for mothers. And so my understanding is there's roughly about 34 states that has this option for coverage, and we do not have that here in Nebraska. So trying to see if we can get some postpartum coverage for mothers after birth is really, when you talk about foundational things in this community, making sure that is available to them is truly important. So that's one area. And then the other would be continuous eligibility for Medicaid and CHIP. I think there was a previous question related to Medicaid redetermination, and we're going to be dealing with some issues after April 1st, I believe, but trying to coordinate eligibility for those that are on the Medicaid rolls. And so anything that we can do to alleviate the administrative burden for individuals to ensure that they can continue care, having that base of insurance is going to be important. So there's a number of bills that will be championed. I think there's upwards of probably 12 to 15, but those are the 3 priority ones for us, at least at this point.
Okay. Thank you. You got another question? Oh, excuse me, Dr. Jones.
Thank you, Kenny, for the information. So I guess what are the priority areas from the CHNA that Charles Drew is focusing on for this cycle?
Yeah, it's the core of what we do is really addressing the social determinants of health, and all of the health centers across the country. There's 16 clinical performance measures that we're all measured up on. So again, the federal government is pretty clear on how they see health disparities and health equity, and the resources that they provide us are really to try to address those core things, and that range from mental and behavioral health all the way down to managing hypertension and diabetes. So the core of what we do and what we stand for in terms of health outcomes is pretty straightforward. I think the levels of intensity from a priority standpoint will shift to a certain extent as we look at how do we partner with the broader health system. So mental and behavioral health is top of mind, and really addressing issues related to substance use disorders and trying to make sure that we provide services that directly impact the population in that space. Looking at more downstream challenges, when you look at the environment and built environment, a lot of our families that are dealing with food insecurity, stability in housing, lack of opportunity for employment and education are all issues that are creating challenges from a health outcome perspective. So I would say staying focused on those 16 clinical performance metrics and making sure that we're advancing health equity in those spaces, and then really zeroing in and honing in on mental and behavioral health.
Great, thank you.
Jeannie, you had a question? Okay, Kenny, don't see any other questions. Thank you for your time.
All right, thanks everyone.
Appreciate it. Moving on then to item C under presentations and the update on the racism as a public health crisis resolution. Jamin, Andy, morning.
Good morning, members of the board. I'm Jamin Johnson, Health Equity Advisor at the Douglas County Health Department. And I have brought along with me today Andy Wessel. We're going to kind of tag team through this. The Office of Health Equity has now been up and running in pretty much full capacity for about a year now. And I had promised this board that I would give periodic updates on your expectation and directive to us to prioritize taking the Board of Health's directive on, or declaration rather, of racism as a public health crisis and actually operationalizing that and what that looks like. So we're going to take just a few minutes, so bear with, and we will kind of tag team through a presentation that we've created for all of you, and then we'd be happy to answer your questions.
And part of the fun part is that we've been invited several times nationally to present on what Omaha, Douglas County is doing around our racism as a public health crisis. There are a lot of health departments that made the declaration, but then they didn't really know what they were going to do afterwards. And so the fact that there were 22 action steps built into this, and then we've been following through from that, and the fact that we're Omaha, Nebraska, and not a Seattle, King County, or New York City has, prompted some interest. But part of that then is we got to kind of orient people to Omaha and Douglas County and give them a little bit of our history and help them understand, why racism is a public health crisis in Omaha, Nebraska as well. We would also be remiss not to talk about, and we make sure on those national presentations to talk about whose shoulders we stand on. And so Dr. Frank Peake, for a lot of years, was, really a prophet, was really preaching the gospel of health equity, racial justice, what needed to happen within public health on that work. And he didn't get to see where we are right now. And so that's one of the things that's really great. Also, just, an acknowledgement to Stephanie Tyrants and then Shavana Loster on the great work that they did really getting minority health and then health equity team established at the health department that really gave us a foundation for being able to do this work. A critical point to talk about is really the work that got started in 2019 with the Racial Healing Project. For many of you, you know that City Match works nationally on maternal and child health issues, but happens to be based here in Omaha, and so we had a little bit of an inside track on getting to work with them on when they went ahead and did a revival of their Racial Healing Project. That was really foundational for then setting up the fact that the Board of Health did declare racism a public health crisis, and that we had some idea of what needed to be built into those action steps to be able to follow up on that. Again, not alone in this. Lots of other, the link there will give you the updated data, but those are the places around the country that also went ahead and made a declaration.
And we want to be intentional when we talk about this, about showing this map, to show that we're not alone, but we also, there's an awful lot of work to be done. And we really have adopted the philosophy that if it can happen here, if we can make this work meaningful, impactful, and actionable in Omaha, Nebraska, and what other parts of the country consider flyover states, then it can happen anywhere. And so this is really an opportunity for us to recognize sort of the visionary leadership that has built our opportunity to do this work every day.
So, Jamin and Andy, because you got the master Zoom, can you box that so it's to clear it up a little bit for people that may be looking to make it like one box or level for the sidebar there?
What's going on?
The people.
Yeah.
Get that.
There you go.
So you can see it.
Thank
There you go. Yeah. So wrapping your head around 22 action steps, I will say even looking at it all the time is a bit of a challenge. To sum that up, we have basically 4 strategic directions. One really is that there needs to be a foundation for this work within the department. Office of Health Equity getting established, key part of that. The Board of Health also establishing their Health Equity Committee, having people that are doing this work day in, day out, having staff that are dedicated professionals doing this work day in and day out. That's really what Strategic Direction 1 is built around. Step 2, you guys heard about the infrastructure grant last month from Jamin about that. that really speaks to this second part, that this then can't be siloed off in just the Office of Health Equity. This is work that is everybody's work in public health, so not just the health department, public health, health sector. This is everybody's work, but we got to figure out internally what that means for how we do the job within the health department. Obviously, the infrastructure grant's going to play a huge role in being able to do that.
And as we move through these slides, we'll explain how we're able to leverage these opportunities to operationalize these strategic directions, even in the way that the office is constructed.
So third piece is, okay, great, we get our house in order internally. What does that mean for community members? So obviously there has to be a community impact, and that means partnering with, our healthcare systems, with the public sector, with community-based organizations, with everyday community members in terms of how we do this work, and being really intentionally on who is out ahead of us in terms of racial equity work, health equity work, so making sure that we're partnering with them, aligning well with them. The whole point, we don't have to be leading all the time. In a lot of cases, it's just figuring out how can we help. Last piece, there needs to be a way that we're being very intentional about taking a health equity lens. When we look at these issues, how are we making sure that we have an approach that's consistent, that's fair in terms of looking at these issues, and that's both on the data and policy side, both internally and externally.
And that's really what that's what sets us apart as us being able to prioritize this as a public health crisis and apply public health approaches to addressing it is making sure that we are walking through the steps that we would in any other public health crisis that we've been trained to address.
This is a slide that gets shared nationally on when people have looked at sort of the gamut of these declarations, and in particular then the organizations that are following up on implementation. These are the kind of things that stand out. And what you'll see is that there is a lot of alignment with what's built into our strategic directions and what people are seeing nationally. Give you just a second to finish scanning those. Okay, so we're not going to go too deep into everything that we're currently doing, but we wanted to give you enough of an overview that you have some sense of it, and then we'll talk about where the work's heading and opportunity to ask questions about any of the current work or where we're headed. So part of this is, again, getting this place about being unapologetic of this work, and that's one of the things that's really great about having the declaration in place is that it's just understood that this is our work. This slide here is really a blend of the work from the Racial Equity Institute with their groundwater approach. If you're not familiar with that, please look it up. But that really talks about structural racism as something that's toxic. And so taking that and then building that into what Kellogg's done around their truth, racial healing, and transformation work on talking about we have to reject the idea of a hierarchy of human value, that it really is that piece of everybody has to be treated as a human being, and that's enough. So that's really trying to connect the dots for this of rejecting that hierarchy of human worth. Everybody just matters because they're a human being, therefore their health matters, and then showing some of the ways in which there are cultural impacts that ultimately turn into health impacts.
And as a department, we boil this down simply. The simple message from this is we are people-centric and people-first. And so this is a colorful and neat way of getting to that point, but it's the recognition that as a department we need to prioritize people first in everything that we do, and as a result, the outcomes we will see positive outcomes as a result of that.
So some of this work is in partnership with our healthcare systems, as well as some of the other groups. Like, have to give a shout out to NACI, National Association for Health Service Executives, really about increasing Black leadership in healthcare. Been partnering with them on what we're calling a cultural healing campaign. Essentially, like, boiled down, you can't say that you're dedicated to doing no harm if you're not focused on racial justice. It's that simple. And so, and then to be able to do that, part of it is you have to know the history. You have to know the history of our community as well as the national impacts. How does that impact people's idea of trust, people's idea of health, healthcare, all of those sort of things. So working with the partners on the left and right that are reflected here, one of the big pieces that will be coming out here very shortly, it's so close to being wrapped up, is a health equity timeline that's modeled on the civil rights timeline that was created by Noise. So we'll be looking to sharing that with you. One of the interesting things was when we looked nationally to try to find the similar sort of timeline, just didn't exist. So excited to come up with that. One of the other pieces that gives an example to making sure that, again, we have dedicated professionals to be able to do this work, but that it's working across the department, MPOCs, and the response on that is a good example of that. Incredible work done in collaboration with the Office of Health Equity, with our epidemiologist, and with our clinic staff in terms of how do we message this, how do we talk to this, how do we relate to the people being impacted by this, and so that really is, again, one of those examples of having the value of having this office in place, but then also ensuring that it's not siloed.
And recognizing the the strengths that exist in the other parts of our department, that we really can and do function as a a well-oiled machine, and that we can allow for shared leadership in some of these responses to unexpected situations in a way that really does elevate our response and the way in which we provide basic services to the community. So I think that this is definitely an example of our senior leadership team recognizing their own strengths, and then the need for sort of a broader collaborative approach to addressing an unexpected situation. So.
And one of the things that I'm personally really proud of our health department for doing is putting accreditation under the Office of Health Equity. The version 2022 standards for FAB around accreditation really did emphasize health equity to an even greater degree. And so it made sense in a lot of ways to do that. But that's one way of we're just, again, taking the declaration and then making it actual by making sure that this key area in which we're improving the way that we do business is just directly tied in. Another example of, again, where there's opportunities, one of the things that happened with the Knox Creek fire was, the evacuation order went out. It just went out in English. There were subsequent efforts to make sure that that alert could go out in Spanish as well. That was necessary, but we felt like, well, we've been doing all of this work, sort of building relationships with our refugee, immigrant, and migrant populations, being able to get COVID educational videos out in over 15 languages. So why don't we just take that and see if, instead of videos that would be created in 2 days to 2 weeks, could we come up with a system that could do that in 2 hours if it was necessary? So been working with our REM serving organizations, particularly Restoring Dignity, who is the one that had taken the lead with creating those videos, and then how do we come up with a strategy for how we can do that locally? And so that's partnering with the city, but as well as our utilities, so BPD and MUD as well.
And really, this is another example where we learned from past experience in a way that strengthens our department more holistically. Our relationship with our emergency response coordinators is critical. We cannot do the work that we do without them. And so being able to identify sort of at a 30,000 foot view the impact, the negative impact of some of the delays in the way our broader system responded to a crisis within our community allowed for us to start thinking in the space that we occupy about the impacts that had on disparate populations. And at the very same time, our emergency response coordinators were thinking very similarly about how to improve coordination and collaboration in the way in which we respond to these crises in the future. And so being able to work together on those things and break down those historical silos is definitely another example of the way in which we're building a 21st century health department.
Okay, so that's again a sample of what we've been up to. Here's some of the work that's on tap. Infrastructure grant, obviously. One of the pieces that's going on with the healthcare systems was we did get selected to be part of a learning collaborative. It's Institute for Healthcare Improvements Pursuing Equity. So that's an exciting thing. We've taken a workshop that was developed in Michigan and then done a train-the-trainer, have about 20 trained facilitators to be able to do. In Michigan's Health Equity and Social Justice Workshop, we're just going to flat out call it Racism as a Public Health Crisis Workshop. Here, similarly, one of the things that was a very specific action step was around implicit bias training for the department and the board. You guys have all talked about the legal epidemiology work that we're building towards. Again, data side, getting to that point of better data partnerships, and then being able to make it easy for people to access our disparity and inequity data. Strategic storytelling projects. So how do we talk about this work in a way that is powerful? Yes, the data matters. Yes, the data is critical, but there's still ways to communicate that are more humanizing and more relevant often for people. So how do we do that work? Some of the work, the follow-up of the emergency messaging stuff is the language justice and simultaneous interpretation training, and then trying to get to the point where, yes, we can come give an oral report, but how do we have it written down as well? So trying to take a page out of Mappa's book to be able to provide that. And then really looking at what we're hearing from the community, both from our advisory meetings and then the oral histories that we've done, both internally and externally, doing some qualitative analysis on that to really hone in on what did we hear, you know? And so that's, you know, some of the work that's on tap. Any questions, anything that you want to know more about?
And if I could really quickly just circle back on that last point. So, as most of you will recall, one of the things that we, as a department, and in very close partnership with our health promotion team, did in response to COVID, and as a direct result of the CDC Health Disparities Grant, was conduct community COVID advisory groups. So we served as a convener. We listened, we opened a space, we tried to allow for community partners to lend their voice. And what we recognized that is sort of a inherent challenge or maybe misstep of the public health profession is that we are really good at listening, but that we are not necessarily as good at then translating that into a product that conveys that we heard community voice and that we have that as a reference for the way we act and respond in the future. And so we had the opportunity to gain a great deal of qualitative responses from community partners from both North and South Omaha regarding their perception of how we responded to COVID or COVID recovery, their perception of the challenges and barriers that exist within our community more broadly or historically. And we feel very compelled and convicted to make sure that what we are doing is intentional and that we are recognizing the expertise of people within our community who are trained and skilled qualitative evaluators who can conduct some qualitative analysis on the responses we received from community members and create a product that we can give back to our community partners who gave us their valuable time and insight and voice in a way that recognizes that we've heard what they have to say and that we are using that to sort of drive our decision making and our strategic planning forward. And also it can serve as a historical guide so that the next time we find ourselves in an unforeseen public health crisis, we can remember that our community members have already spoken about the barriers and challenges of how we respond or the system that exists within our community and where we fit within that system so that we can try to mitigate the chances of repeating those errors. So that is something that we are intentional about doing within the Office of Health Equity, is making sure that we commission a qualitative analysis of the community convenings that took place over the past 2 years.
I've got a follow-up question with that. Is there a summary report available, and is it transparent to the community to look at as well?
That's what we're working to build out.
Gotcha.
And I think that was one of the realizations is that we were sitting in the room, so we heard the responses, but we have a responsibility to communicate that out in a way that is accessible. And so that's kind of the step that we need to take.
Great. And then can you elaborate a little bit on the health equity dashboard and what you envision kind of being a part of that?
Sure. So I gave sort of a primer several months ago about a health equity dashboard, looking at. I love that that one of the central themes of this meeting today has been around maternal and child health. We all know, I've said it before, that my heart lies in maternal and child health, and being able to apply the life course perspective to the way in which we identify key health indicators within the Office of Health Equity to give us a real-time picture of the impact of disparities on populations within our community, and use that as a way to be nimble to adjust the way in which we are doing our work and targeting our interventions. It's critical so that we can make real-time decisions that impact people fast. And so, that meant that we had to, one, identify a way to communicate the impact of disparities broadly without going down a road where we are distracted by misunderstanding around challenging topics and words. So we know that for example, infant mortality, babies living to their first birthday, is not a controversial topic. Most people would agree that we wanted to see our babies make it to their first birthdays. The same regard, the average life expectancy, we all have probably the shared belief and hope that we will live long, healthy, and productive lives. And when we see a reduction in that life expectancy, that is a really great opportunity for us to recognize that there are disparities at play that are reducing people's ability to live long, productive lives. And then I love that that our friends at Charles Drew talked about the impacts and the relationship that exists between education and long-term health outcomes. We know that they are inextricably linked, that you cannot separate the two. And we know that there is a direct causal relationship between life expectancy and graduation rates. And so as a midpoint in the life course, looking at our community graduation rates, that gives us a really good kind of proxy measure of the impact of disparities at play that are going to have a long-term negative impact on health outcomes. So being able to build out a dashboard that highlights those three key health indicators and allows for us to plug in other indicators along that life course as we identify the impact of those disparities really is the vision for our team. I will say that we are really excited that we are much, much closer to having another health equity epidemiologist on board, and that is really critical for us to be able to build out this dashboard, is making sure that we have a well-formed team to be able to not only build it but maintain it so that it's accurate and telling the right story. So our hope is that we can get that off the ground and launched very soon in this next several months.
Last thing, I promise. I think before, when you guys had kind of given us a introduction to your work, that we had kind of talked about how are we serving to kind of collaborate activities, especially surrounding the CHNA and everybody's CHIP work at their own institutions. How are we as Douglas County Board or Douglas County Health Department kind of helping to really center the priority areas for each of the organizations and then kind of give a vision to that work, I guess?
Sure. So I think we can kind of boil that question down into two parts. So the second half first. I'm gonna start the second half. So first, there needs to be an acknowledgement, and there is an acknowledgement within our department that the Community Health Needs Assessment provides a roadmap for us to identify the community-based priorities, but also the strengths within our system. So we need to be able to acknowledge those areas where we maybe aren't positioned best to lead, and where our hospital system partners are better positioned to lead, or our community-based organizations. And so that's part of it. And I think the other part, the Douglas County metro community is unique in that we have conducted a regional metropolitan community health needs assessment. I think it's really important that we not overlook how important that is, that our hospital partners, our public health agency have worked together to build this out. I think that there were challenges in the fact of timing in which the last iteration was completed. It's really hard for us to, I don't think it's fair for us to fully judge the way in which we implemented the work around the identified priorities after the pandemic did strike. But what we need to recognize is we identified some significant strengths, and one of them is that we talk between each other within this broader system. And the second piece is that we have forged some shared community-based goals. So I think that we are, as a department, positioned well moving forward, in that we have now, we have some senior level leadership positions that have transitioned and are now fully up and running. So we have, we have Leah's section ready to take a significant lead on our community health needs assessment, and my team is poised and ready to bring all of our resources to bear as well. And we've also forged really strong partnerships with our community-based partners. I mean, they've existed, but it's been a challenge in that, sometimes we're like ships passing in the night. We've worked really hard over the past year to strengthen those relationships, to recognize that sometimes our responsibility is just to show up and listen, not to show up with ideas. And in doing that, I think that what we will see in the next round of the community health needs assessment is something that is reflective of our broader community, but also actionable, in that we can break down who is responsible for leading each part of the work and be okay with saying that sometimes it can't be us. There are pieces that we're not positioned well to lead in, and we have to acknowledge that.
And the only thing I would add is that pick your issue, there's going to be disparities and inequities that are going to show up in it. There's not always going to be, race and ethnicity. Sometimes they're going to be age. Sometimes they're going to be, LGBTQ issues. It's, I think in the course of making sure that the work gets done on whatever priorities, say mental health, that those inequities get raised, and that how do we make sure that we're doing an effective job of both raising those issues and making sure there's action taken on it. I think that's a piece we can add.
There was one question online from Dr. King. She asks, do the steps need to be completed in sequential order, and if so, what step are we on, and what steps have been completed or started?
I wish
That's a great
that
question,
they could be
Dr.
completed.
King. No, the steps. So honestly, the realization is like some of these steps will never be completed, and that's okay. Like we need to have. We need to recognize that a couple of the strategic directions require that we continue to grow, that we continue to educate our workforce, that we continue to modernize. I don't want to ever say that we've accomplished that, because then we stop growing and working. The other factor is, we have a responsibility. We have a responsibility to be able to boldly address the impacts of racism as a public health crisis, and unless and until we can come up here and say we've solved racism, then the work around this topic and the work situated in these strategic directions will never end, and it has to be done in tandem. It requires us to take leadership, and then part of the responsibility is building out core competencies that others hold us accountable to. And so that's really work of the community to recognize their power and authority, and holding us accountable to doing the work that we've been charged with doing. So from that perspective, I would say that all 4 strategic directions have to be done in tandem, and will continue to be done in tandem probably forever.
Go ahead. I have 2 questions, but I'll let you answer the first one first. In regards to that community health needs assessment, just for general awareness, actually we are hitting the time where we need to start looking at the tool and really look at and prepare the tool for being released at some point in 2024. So there'll be a lot of conversation across both the the pediatric version, but also the adult version of, is this still the right tool? How do we need to continue to tweak it, make it better? I really see within this next round, I would like to, there's a gap when it comes to the community health needs assessment. There's populations that are left out because it's only offered in English, only offered in Spanish. We really haven't gotten the refugee voice in there, et cetera. So just any thoughts of how we can apply that broader lens to this next iteration?
For that specific issue, again, as awful as COVID was, it pushed us in some directions that were necessary. And one of those pieces was building the relationships with our refugee populations. So figuring out how to do that and having people that then can translate or figure out, like, that's doable now. It's not easy, but doable.
Right. And it'll be an additional cost. So I think the health systems, health departments have got to recognize that it's valuable enough that the investment into and covering that cost is key.
I was just going to add to that too. So with our community health improvement plan,
Come to the mic.
With our community health improvement plan, we've actually started implementing having Karen as one of the languages, and we have found some of the things that came up with our partner that is kind of putting on the mental health community surveys, that sort of thing. We found some issues, so we're kind of hammering those out so that when we do our next reiteration of the community health assessment, we'll be able to kind of tackle those. So good question.
Great, thank you.
Yeah, there's some conceptual things like the word depression is not, there's no like one-to-one translation. So you have to ask like questions about like, are you sleeping all the time? Or do you feel just exhausted and tired? You know, the different ways to ask that to get at a concept that we have, you know, developed in English that's not developed in Karen.
Then my last question was, as you do this work, how can we as a board be supportive, and what do you need from us?
Yeah, I think one is honestly the continued accountability. I mean, you gave us 22 expectations that we need to be addressing, and that's just the beginning. That's just the tip of the iceberg. So I think that these continual opportunities to come back and share about the work that we are doing is one of the most important pieces in holding us accountable to the work. And then I think the other piece really does revolve around lending your knowledge and expertise. You're each expert in areas where we're not, and you have influence and access to populations with our community that we don't. And so being that voice and that ear is really helpful for us to be able to understand the areas in which maybe we need to shift our focus or direction. So I think that those are really the two big pieces that that I would ask for your continued support in.
And I'll just add to that, like, people get into public health or healthcare, the health sector in general, because they are like dedicated, compassionate people. And then sometimes that seems to get in the way of us being unapologetic or when it comes to advocating for the health needs of our community. So that would be my other piece that I feel like the board is doing well, and just to keep doing it, just being unapologetic in terms of what our community needs when it comes to their health.
Dr. Figgs had included a comment online that I wanted to address just very quickly. He brought up that we often take for granted that we all know what race means. There's actually not a great definition for race out there, and developing kind of shared understanding of what we're talking about, I think is important. One way that we can do that is by becoming more informed and more educated and kind of understanding history and how we got to where we are. Nonprofit Association of the Midlands is sponsoring the Racial Equity Institute, and if any of you have not gone through their 2-day
phase
course,
one is what that one is called. Phase one, yeah.
If you haven't been through that, I highly recommend it. I've been through numerous cultural competency, health equity, inclusion, kind of broad trainings over the past 22 years. This is by far the best one I've ever been in. It was honestly pretty earth-shattering. So I know that they have some courses that are set up throughout 2023. So I highly recommend contacting them to see if they have any openings if you haven't ever
They're
gone
starting
through
to
that.
fill up. Yep.
It's very popular and it goes very quickly. Just be prepared. It's pretty emotional and heavy, but incredible. And I think would be a good lens for people to develop to bring to this space.
Dr. Hughes, could you repeat that resource?
It's Nonprofit Association of the Midlands is who's hosting it, and it's the Racial Equity Institute. Phase 1 training.
Yep. The groundwater trainings, they're short and sweet one. Phase 1's the longer 2 days.
You want the phase 1.
Yeah.
May I make a comment here?
Absolutely.
My emphasis or my concern really was, are we using a specific definition or are we using several broad definitions? What is our thinking about what we're really referring to when we say race and racism?
For the sake of time, let's work that out outside the meeting, because that's a
Okay.
deep question out there we're gonna solve today.
It might be partially defined in the declaration. I
Yeah.
mean, a working definition anyway, so we might look there.
One of the action steps is to rework the health equity policy and including a glossary of terms in that. So that's work that's actually some of that's gonna kick off tomorrow with those community advisories.
Okay. Well, you all should be prepared to
Yeah.
answer that.
Okay.
Just a comment. For me, this is probably the most important work that we're doing here moving forward with public health services, being able to really identify the growth and the diversity that it's coming to our Omaha City and Douglas County. And I just wanted you to speak a little bit about the work that the Health Equity Committee is doing and how important that time commitment is from our community members to really support the work that you're trying to complete here.
Yeah, thank you for that. I will say that the Health Equity Committee, which is a subcommittee of this Board of Health, is, it is another opportunity for us to really hear community voice and to get community perspective and leadership on things. To have the opportunity. I mean, Andy spoke to some of the big pieces that we are going to be working on, which is, drafting and revising our health equity policy within the department, to have the ear and the eye of a policy board to be able to look at it, give recommendations and feedback is really important. And, really the commitment that the members of our community who sit on that board provide is critical. It allows for us to really be able to access parts of our community that otherwise we would not be able to access and hear voices that are not necessarily always represented. I have always recognized in my career in government that we usually don't have a shortage of opportunities to hear from the loudest voices in the room, but oftentimes the quiet voices are sometimes the voices we need to hear most. And I would say that that this subcommittee is a great example of being able to offer an opportunity for those quieter voices with really important things to say to convene and give insight and guidance and leadership and direction to the work that we're doing as a department. So.
I'll just add to that very quickly. I know we're past time, but we also internally are about 2 to 3 weeks away from having the Office of Health Equity on a level playing field with all other divisions within the department. So it won't simply just be a program, it will be a division that plays on equal footing. And we feel that that is a very concrete way for us to show our commitment to health equity and also to ensure that it's not just through the Office of Health Equity that we're having these conversations, but that we're finding ways to ensure that everyone in the department is able to listen well and to respond well in this space.
So for the record, Dr. Jones has brought to my attention, there is some language in that resolution that talks about race and some other things around it, so we can go there to read through that. Seeing no further questions, I'll wait and talk to you all just for the sake of time, but thank you for the update. It's a good piece, and I'm glad to hear that epidemiologist position is close. With that, for the record, if anybody has questions based on the reports from the department, oh, excuse me, sorry. Leah, do we go over yours? You're on the overdose death review. Did we go over that in the bills, or is there something added that you need to do?
We talked about it in the bills.
Yeah, I think
Okay.
that was just kind of the update on where we're at.
Okay. So then with that, if anybody has any questions based on the reports, if they could ask them to Dr. Hughes and she can get them answered. Again, I want to apologize just for the time. When we moved the time back to 8:30, so we're still adjusting. The goal is to get everybody out here to 10. And so we'll make that adjustment next time. For the board members though, if everybody's fine with the status of officers as it is, then I'll just ask Dr. Hughes to put a resolution on there ratifying those for another year. If not, please let me know and we'll go about the methods of going about that. With that, again, it's nice to be home back in the legislative chambers. We'll be here 8:30. We'll make the adjustments to get it there at 10. And thank you all for being in attendance. With that, is there a motion to adjourn?
Just start with the share.
There's a motion by Wise, second by Festerson. Roll call.
There you go.
And this is for what?
Adjourn.
To adjourn. Okay, sorry. Rogers,
Yes.
Weiss, Jones, Festerson.
Yes.
Wilkin, Espinoza.
All right, see you all. All right, thanks.